in Rochester. She is a world-known authority and physician in pregnancy-induced hypertension, and has been referred multiple times for this topic. So we are really honored to have such a renowned faculty for giving our grand rounds today on pregnancy-induced hypertension.
Thank you very much for this kind introduction. Indeed, I'm professor of medicine at Mayo Clinic, and I'm a research chair in the Division of Nephrology and Hypertension. I also have a joint appointment in our Department of Obstetrics and Gynecology, predominantly because of my clinical and research interest in this field. My talk today is going to address briefly some of these relevant research topics, but it is also going to be heavily on the clinical side in an attempt to give an update as to the most recent development with respect to treatment of hypertension in pregnancy. So during this talk, I will try to touch upon important issues related to hypertension in pregnancy, including pathophysiology, diagnosis, management, overall outcomes, and where the whole field is going to. I think that it is highly recognized that placental ischemia is playing a pivotal role in the pathophysiology of preeclampsia. What actually happens is that in preeclampsia, the process of development of small vessels in the placenta is impaired. Abnormalities in this process result in maintenance of high resistance, low capacitance of maternal spiral arteries with a consequent placental ischemia. This theory is there for a number of decades, and the disease of placenta has been considered to be the main pathophysiological event in the pathophysiology of preeclampsia. However, we now recognize that in some forms of preeclampsia, placental disease is absent. In other words, what we think when we say placental disease, we are referring to small placentas with infarcts and with a consequent intrauterine growth restriction. However, this does not happen in all cases of preeclampsia. So in placental preeclampsia, this is what we typically see. We see spiral arteries, which really should look like these ones. They are wide with a remodeled arterial wall. In placental forms of preeclampsia, some of these spiral arteries remain relatively of a small lumen, and they do not undergo that normal physiological process. This, again, does not happen in all forms of preeclampsia, because in some forms, placenta is completely normal without infarcts, and babies are of normal gestational weight. Therefore, we are more and more talking about maternal preeclampsia, which is characterized by endothelial dysfunction that predates pregnancy. Regardless of whether it's maternal or placental form of preeclampsia, ultimately there is a systemic disease with involvement of kidneys and the heart that result in clinical features of preeclampsia that are characterized by proteinuria, hypertension, diastolic dysfunction in some of the patients, that actually all of these pathological changes together give a vicious circle of sodium retention, water retention, hypertension, and clinical phenotype, which is characterized by proteinuria and hypertension. Later in life, some of these pathological changes may persist, resulting in increased cardiovascular disease and hypertension, and we will touch upon that later in presentation. So in terms of pathophysiology, given these most recent advances, I think it's important to understand that not all women with preeclampsia have placental disease, that some of them, they don't, and that form is typically referred to as maternal preeclampsia with endothelial dysfunction, which may predate pregnancy. I think it is accepted for a number of decades nowadays that endothelial dysfunction plays a major role in the pathophysiology of the disease, and it's actually underlying mechanism for systemic character of preeclampsia. Dysregulation of angiogenic markers have been recognized for the last couple of decades as a possible mechanism that results in endothelial dysfunction and hypertension. However, it does not really provide a good mechanistic explanation for early renal damage and proteinuria in preeclampsia. And my laboratory was the first one to describe dysregulation of podocytes in preeclampsia, and subsequently several other labs have confirmed our findings. So podocyte is basically a glomeruloepithelial cell, which is located at the outer aspect of glomerular basement membrane. It is characterized by the presence of food processes. This is a cross-section of those. And these food processes interdigitate among themselves through tight junction barrier, which provides ultimate barrier for the occurrence of albumin in the urine. And proteins that are actually building blocks of this tight junction barrier are synaptopodin, nephrin, podocin, and podocalixin. And these are the proteins that are actually focus of my studies in my laboratory. We have shown that podocytes can occur at the time of delivery and during the second trimester. In other words, podocytes, which are terminally differentiated cells, get detached from glomerular basement membrane and are present in the urine both before the occurrence of clinical signs and symptoms of preeclampsia and at the time of delivery, which actually led us to hypothesize that podocyturia may be a sensitive and specific test for the diagnosis and prediction of preeclampsia. This is a relatively new theory. We are working on further sophisticating diagnostic and predictive measures, but this is definitely one of the venues in which this field is developing. So that much about pathophysiology of preeclampsia with respect to the underlying mechanisms of hypertension and proteinuria.